Thank you very much for coming back. I'd like to introduce the next speaker, general medical oncologist. In one way or another, when we get the feedback that Laura will present as well, actually these are the doctors you're a lot more interested in than seeing us. It's funny that ocular oncologists always think we do a great job, but what you're interested in is obviously the disease outside the eye, a lot more than anything else. And it has been a strange phenomenon that these doctors never existed really until recently. I don't know whether you share the same frustration sometimes that you refer a patient to an oncologist and basically you get the vibes, we don't want to see this patient because, blah, 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 I've never seen one, or we don't know and you can't do anything. And then they may even mix it up with skin melanomas and don't really know what they're about. And this is about to change, fortunately. So finally, and we're very, very fortunate to have oncologists specializing in this small group of patients. So that main focus of them is really looking at the extraocular disease of ocular melanoma that is so important to you and to everybody. And we're very fortunate to have a team here in Liverpool now is really looking into this and driving this field forward. We all hope that there will be obviously a cure one day. We're not there yet, but the first steps and first results are quite exciting, and I'd like to thank Joe for presenting the data here. Thank you.
Thank you very much. It's really a privilege to be invited here, and Catherine, nice to put a face to a person. Now I can't find her anyway, but hi. It's always a privilege to speak to a group of people who've been through this very difficult time. And I'm not sure about that introduction, Heinrich. It's putting too much on my shoulders, but at Clatterbridge, I work in a team alongside Ernie Marshall, who's another medical oncologist, and Doug Errington, who's a clinical oncologist. And we also have a specialist nurse Joe Upton, and we then work very closely with Aintree, with Steve Fenwick and his team, and with interventional radiology and so on. So I absolutely agree that having people working as specialists within this field and within an integrated multidisciplinary team is essential really to get better in doing what we want to do, which is to treat this and eventually to cure the cancers. So the bit I'm talking about is treatment options for metastatic ocular melanoma. And really, I'm going to speak very briefly about spread of ocular melanoma, which most people will know in the audience. And then the first step would be surgery to remove a metastasis. Second, locoregional, which is liver-directed treatments, and then systemic ones, which through the bloodstream to affect all sort of organs. I'll stray slightly off topic at the end and really talking about what I think is perhaps the most important thing, which is preventing metastasis from developing, how we identify metastasis early, and the importance of particularly randomized trials at this time. Now, I would also hasten to say I've got slide envy after Sarah's talk. Mine are almost all text slides, so I apologize for that. But really, the treatment of, as we've heard already, the original tumor in the eye is almost always successful. And with more and more patients are managing to get this with sight being spared. But unfortunately, in about half of all patients who have ocular melanoma, the cancer does come back at a later date, albeit in a different organ. And this involves, prior to the treatment of the primary, the break-off of some single cells or small groups of cells that then get into the bloodstream, travel into the organ, which is normally the liver, and then can lie dormant or grow very slowly over many years before they're detectable by the technologies that we have available today. The liver is the most common organ in the body to be involved, particularly initially, and latterly other organs can also be involved. Unfortunately, at the moment, we do still have limited treatment options, and the aims that we can achieve are to control rather than to cure the disease at this stage, in the main. So, starting off with liver surgery, the liver we know to be capable of a very high degree of self-regeneration. And when the metastases are few in number and located in such a way to allow it, surgery may be possible to actually take out the lumps of cancer within the liver. And this is a slide from the internet which shows that if you have cancer in one part of the liver that you can take out, you can leave a considerable enough of the liver to recover afterwards. Now surgery has moved on considerably and now can be able to take out several different areas of the liver as long as the remaining liver has sufficient blood supply and is large enough to maintain itself. So with time, surgeons are becoming more aggressive in what they can actually try and do. And from previous reports from Paris, for example, we know that removing all the visible disease can lead to prolonged control of the disease. And we've just been looking back at data over the last 10 years from Liverpool, and we've had around 20 to 25 patients who've had surgery to remove metastases in that period of time. And the average survival has been about 2.5 years, which with some patients having survival for longer than 5 years, and hopefully for some of them this leads to cure. But unfortunately, surgery is only possible at the moment in 10 to 15% of cases. We work, as I say, closely with Aintree to assess operability. First of all, when we think that there's a possibly resectable liver lesion, we arrange for them to have a contrast MRI, CT chest, and then review by the surgical team to see whether they feel that this is operable. They'd have another check, which is to do a laparoscopy, keyhole surgery, to check and see the liver itself from internally, whether there's any evidence to indicate further spread. And once they've had the liver resection, they would come back to us and continue on surveillance. If they're unresectable, then they have other treatments that we will come to in a second. It is another adjunct to the surgery to some extent, or sometimes used alone, is ablation of the lesion. So this is actually using heat to kill off cancer cells within the spots in the liver. And we use the various technologies, including radiofrequency ablation, which is the one that we most commonly use, microwave ablation or cryoablation, all of these involving a catheter, so a long, going in through the bloodstream, putting a long sort of probe into the liver, and then blasting that with radio waves or microwave waves and so on to try and kill off the pits. And sometimes that can mean that you can use that in conjunction to surgery to get at ones that you can't with the surgery, or sometimes it can be used alone. And stereotactic radiotherapy or radiosurgery, which involves using a very focused beam of radiotherapy or multiple beams to direct to one very specific area of the liver, is also under investigation. The other kind of option that is available if surgery isn't possible is locoregional therapies, which means that we're trying to treat into the liver itself, not the whole body as a whole. And this kind of infusion into the liver offers the potential of having very high concentrations of the treatment within the liver while sparing the rest of the body from the side effects of the drug. And the hope is that that can lead to better responses within the liver with less side effects. Technologies, there are quite a few in development. I'll mention briefly percutaneous hepatic perfusion with chemosaturation, which is, there's a stall outside of Delcath. Might be able to see their video on how it actually works, but I'll give a brief overview. Hepatic intra-arterial infusion, radioembolization or immunoembolization, which are all different ways of trying to focus the treatment on the liver, because we know that the liver is the most involved organ, and sometimes there's no disease elsewhere, it's just in the liver. So PHP basically means that it's a complicated process which involves sort of isolating the liver so that you have a balloon in the circulation to prevent all the blood flow going directly through the liver. And you deliver high-dose chemotherapy into the liver, which is then filtered out of the liver before going back into the circulation. So basically, you deliver very high doses, saturate the liver with chemotherapy, and then put the blood back in as normal. It definitely does result in significant responses, so reduction in the volume of the cancer, and quite high rates. And there has been, in one of the very few phase 3 trials in basically in ocular melanoma, has been using this technology. It used, there were 93 patients who had unresectable, so liver mets that couldn't be taken out, from either ocular or skin melanoma. And then it was randomized, so 50% of patients got Delcath and the others had the best alternative care. After the cancer had worsened, the patients could then go and have the other treatment. So if you'd had the best alternative care, which would normally be a chemotherapy of some form, you could go back and have the Delcath afterwards. And there was an improvement in the time till the cancer worsened, so till it started growing again in those patients who'd had Delcath. But it didn't improve the overall survival, so the length of survival for all the patients compared to the alternative arm. Now, this may have been partly due to the fact that there were crossovers, so that people, a large proportion of those who didn't have it initially went on to have Delcath. But we still haven't got a huge amount of data because ocular melanoma is so rare. Now, later on in this year, there will be 2 institutions, I think, publishing some data or presenting it at major meetings. And certainly anecdotally, some patients appear to have a prolonged survival after treatment. There are questions remaining about who, how beneficial it is and who are most likely to benefit. And there are significant side effects as well, with mortality in a small percentage of people who have the treatment. So I've put currently undergoing commissioning through evaluation in UK, which isn't quite true. It's going through the process of getting to commissioning through evaluation. So this basically means that the treatment option will be available, but will be very monitored to see how much benefit it is giving and audited prospectively. And at present, it's been performed for several years now in Southampton, and Liverpool at Aintree are currently in the setup phase to have this available as a second site in the UK. There are other local regional therapies, as I mentioned earlier, that are being investigated, with the other major trial really looking at hepatic intraarterial perfusion or infusion with the same chemotherapy. And this increased the likelihood of shrinkage of the cancer and time again to the worsening, to the growth of the cancer, but didn't improve overall survival. There are also ongoing trials with selective internal radiotherapy, which basically uses beads that have radioisotopes attached that concentrate radiotherapy within the liver. So you give it into the liver, and that the beads stick into the small parts of the liver with the cancer, and that basically means that you deliver a large dose of radiotherapy within the liver, but spare other organs. So the next step is systemic therapy. Now, this means giving treatment that goes throughout the body, give it either by oral treatment or through intravenous treatments through the vein. And this circulates around and affects all organs involved. And when the cancer has spread beyond the liver, so it's not just in the liver, or if the cancer is too big a volume to be attacked with any of the other treatments, this is the kind of treatment that we have to think about. In the recent years, we've gone from just having some chemotherapy to also having potential of immune therapy and targeted therapies available as well. Chemotherapy, which is something most people will be familiar with, really involves the use of drugs to kill cells that are dividing, multiplying. And the reason we can use this against cancer is that cancer cells divide more rapidly. And so that means that it will affect the cancer cells more than it affects the normal cells in the tissue. But it does have significant effects on normal cells, and chemotherapy can be highly toxic with side effects normally, like causing a high rate of infections, nausea and vomiting, and so on. Unfortunately, ocular melanoma is relatively resistant to chemotherapy. Only a small proportion of people have shrinkage of the cancer after treatment. In ocular melanoma, we normally use dacarbazine, which is the most well-established chemotherapy agent, which has been used for quite some time. But the chances of shrinking the cancer are only in the region of 1 in 10. It is relatively well tolerated, so side effects are quite minimal. But as I say, that's still a very low response rate. At present, most trials use either dacarbazine or a similar chemotherapy agent as a control arm to try and show that whatever else we're using is better than that. And there is, I think, limited interest really now in just standard conventional chemotherapy, although it's still being looked at in combination with other treatments. Immunotherapy has been a really exciting development in cancer therapy recently. So the immune system is the way that we fight intruders, bugs, bacteria, etc. But also, the immune system also acts to try and kill off cancer cells as well. So in the cancers, there's often a battle between the cancer cells and the immune cells, which keeps on going. But in some cancers, like melanoma, the cancer itself has managed to hide from the immune system through various molecular mechanisms. And one of the breakthroughs recently has been the development of so-called immune checkpoint inhibitors, which are really aiming to overcome this ability of the cancer to hide from the immune system. So this is a bit of a complicated slide. In this, just briefly, this is one of the immune cells, and at the bottom, a cancer cell. So the cancer cells have abnormal proteins that they produce that are basically come to the cell surface, and that normally would be recognized by one of the T cells from the immune cells, which would then lead to activation of mechanisms to kill off the cell. But what cancer cells also do is they can express other proteins on their cell surface, which link in to proteins on the immune cell to tell the immune cell to switch off. So to anthropomorphize, it's basically like the immune system working out how to switch off the immune system through these linkages, basically through these different proteins. And the real breakthrough has been in identifying these proteins and finding antibodies that bind onto them and stop them from working and stopping the immune system. So it's a double negative. We shut down this protein, which shuts down the inhibition, and that means that you ramp up the immune system in order to try and attack the cancer. Now, the two drugs that are most developed are ipilimumab, which I'll come to a second, and nivolumab, which have both shown great promise in melanoma. So, excuse me a second. Ipilimumab has shown significant benefit in skin melanoma, but in a proportion of patients. So only a proportion of patients respond to the treatment, but those who do respond can respond for a very long period of time. And we're beginning to think that at least some of them have actually been cured of the cancer. The agents that follow on, like nivolumab, which is attacking the PD-1 protein, look to be even more promising. They result in even better shrinkage of the cancer. And we hope that that will translate into better survival as well. However, ocular melanoma is quite different to skin melanoma, and it may be that the benefits are smaller. There have been small numbers of patients who've been involved in trials who've had ocular melanoma, but because it's so rare, it's been difficult to have a definitive sort of answer as how effective it is. In one study, however, that looked at 39 patients who'd been treated with ipilimumab in the States, they found that only 2 of them had had shrinkage in the cancer, but with a further proportion having had the cancer stabilized, so kept at the same rate, 46% at 12 weeks and 28% at half a year. Now, the downside to immune therapies is that there's a significant risk of side effects, because you're basically taking off the brakes from the immune system, and the immune system can then start attacking other organs like the bowel and cause colitis and various organs and so on. However, this is normally manageable. Until recently, ipilimumab was only available as a second-line treatment, so you'd had to have had previous treatment before you could get onto ipilimumab, and this was on the terms of the trials that had been run and the licensing agreements. But now there's been a change, so it should be available first line, although this is still going through commissioners for funding streaming and so on. In addition, we have a nivolumab expanded access program opening up, and this should be soon available locally, but I think might already be open in some other centres in the UK. And hopefully, with ocular melanoma, we might be getting better responses to that. The final treatment that I was going to talk about is targeted therapy. And this is really where we aim to discover a silver bullet, a way of which we can attack the cells, the cancer cells alone, and leave the rest of the cells completely normal. And this is on the theory that often in cancer there's a mutation which changes just one protein that is different from all the other cells in the body. It is never that simple, but that is the kind of premise that we're looking at. And in skin melanoma, a change in a gene that leads to cancer cells producing a mutant protein BRAF is very important. And in a proportion of patients, this is what drives them to keep dividing. And the industry has developed several inhibitors now against this BRAF mutation, of which the most well-known is vemurafenib. Although BRAF is not mutated in ocular melanoma, I'm using its inhibition in skin melanoma as a sort of example of how targeted therapy works. And this is my rather primitive attempt at graphics. So in a normal cell, you have this protein called BRAF, which it's like a molecular switch. It tells the cell whether to divide or not. And in most normal cells, it's switched off. It's not telling the cell you need to grow and divide because the cells aren't supposed to. When you have a mutation in this, when you change the genes, the protein structure, you put it in, it becomes switched on continuously. So you have this switch now on the on position, and the cells just keep on dividing, so that you get multiple cells produced as this. If you use vemurafenib, then this is designed to inhibit this protein, BRAF, and essentially it then switches the switch back onto off. And because these cells were so dependent on signaling on the signal, they then basically die. At least that's the theory. And we do know that it is very effective in skin melanoma, although it only tends to work for about 6 months or so before other mutations, other abnormalities take over and it becomes resistant. And it does have significant side effects. So the silver bullet side of things is still out of sight slightly. Now, as I said earlier, BRAF is not mutated in ocular melanoma. And there's really an extensive investigation trying to find the equivalent of BRAF within ocular melanoma. And certainly one example is the mutations in these two genes called GNAC and GNA11, which are present in almost all ocular melanoma cancers, and which we're looking to try and inhibit. Now, collaborators of ours in the States, Richard Carval, you saw it was briefly flagged up earlier, did a work on selumetinib in ocular melanoma, which published just a few months ago, really now. So selumetinib is a MEK inhibitor, which attacks a growth pathway that is switched on by these mutations, GNAC, GNA11. So it's not as direct as the vemurafenib story, but it attacks downstream of these mutations. And with the study that Carvajal and his colleagues did showed that there was an improvement in time to the worsening to the cancer growth in those patients who'd been treated with selumetinib compared to those who'd been treated with chemotherapy. This didn't again improve overall survival, but similarly, there was an element of crossover. So at the moment, there's a trial being run by Paul Nathan, who is part of our big group of collaborators, called Summit, which is looking again at selumetinib in uveal melanoma. And there's also a trial in development that will be looking at combination of this with a form of chemotherapy, which should start soon. In addition, there are lots of other MEK inhibitors that are beginning to be looked at. Novartis is another company that is putting effort into working out a combination of a MEK inhibitor with another kind of inhibitor called a PKC inhibitor, which will be there's an ongoing trial at the moment and will open more widely soon. And other company is GSK, which also is working in this field. So though this is very early days from the MEK inhibitor, at last, for the first time, we're actually seeing that improvement with a drug compared to the chemotherapy. And the other thing to stress, there are other changes in ocular melanoma that appear to be important for cancer development. And one of these has been mentioned a couple of times before, BAP1, which is an area of interest locally with Professor Coupland and Judy Coulson's lab as well. So a lot of work in trying to find out how we can develop inhibitors that attack those cancers that have lost this protein as well. So although at present there's no targeted therapy that has been licensed for use in ocular melanoma, there's hope that this will change soon. Now I'm going to finish off by looking at how we can improve the options and go forwards from where we are now. And hopefully just at the beginning of my career, working in Clatterbridge, and I think that there is a lot of potential now to improve things, and I'll come slightly to need to accelerate that as well. So adjuvant treatment involves using drugs or other strategies that are used after surgery. So after you've taken out the cancer or treated it, I said after surgery or radiotherapy, treated the original cancer to try and prevent the cancer from actually growing. Because what we know is that at that stage, there will be, in those patients where it comes back at a later time, there will be tiny bits of the cancer somewhere, but they'll be dormant and or growing very slowly. And it may be that at this stage, we're able to attack them better. And as Sarah's already said, we are now at a stage where we can identify very well those patients who have a high risk. And again, it was mentioned earlier that when you can't do anything about that, it becomes quite difficult to know the benefits of it. But I think it's quite frustrating to people in that situation that that there's a very high chance that it comes back, and yet all we can do is watch. And obviously, the plan would be to develop strategies to prevent that from progressing to the next step. And there are a few trials that are beginning in this area, and I think that will be the most important area in the future, in my view. The other side to it is identifying metastases earlier, so that if they're identified early, we can use surgery to actually attempt to cure it, or at least to prolong survival. And there are lots of different techniques that people use for surveillance. And it's very patchy. Some people use ultrasound, some people use MRI, some people use CTs. And there's actually very limited evidence. Again, Sarah mentioned a trial that we were involved in that looked at MRI that did show that in over 95% of patients, we can identify the cancer before it's causing symptoms. And that means that the possibility of all these other treatments is much higher. But there remain a lot of controversies here. Who to screen, how long to screen, what type of screening. And we're, I think, very keen to try and work on developing trials to improve this whole service. And mostly, I think, also to make sure that what we're using is available to all and is equitable, so that it's not just Liverpool doing one thing, London doing one thing, all these, that kind of postcode lottery. And the other thing about improving options is clinical trials. Ocular melanoma is a very rare disease, and it has been really difficult to recruit patients naturally in sufficient numbers to allow conclusive findings from these trials. This is an example of some trials that were run relatively recently. I think I did this a couple of years ago initially. And you can see from the numbers of patients in the trials that we're looking at as few as 4 in a trial, which is never going to really show you anything. And the maximum was sort of about 50. Have heard, I mentioned the Delcath trial earlier, which had 93 patients, and the selumetinib trial also had significant numbers. And I'll come to the SWAV trial in a sec. But if you compare that with breast cancer, where such trials would have thousands of patients, you could see that it's really important to work together to maximize what we can get from any trial. And that really means that we need high-quality, well-designed trials that really look to answer the important questions, that are collaborative. And wherever possible, I think they should be randomized so that we can compare treatments in one group versus another. We always have the problem where you have a single-arm trial, is at the end of it, you say the response rate was this is how long people survived. But you don't know if that was just because of the group who were lower risk than another group. It's very difficult to interpret. So the SWAV trial was a trial run from locally. Now, unfortunately, it was negative, which is why I've not talked about the data. It didn't show any benefit for sunitinib compared to dacarbazine, which was the question we were asking. But it did show that we could recruit patients onto a randomized study in the UK across multiple sites. And this is going to be vital in the future. And in the sites that were involved spread across the whole country here. And we've now got this network of researchers who very much involved in these trials and can deliver more trials in future. There will be negative trials like SWAV. That's why we do a trial. It's always disappointing, but at least we've got the positive that we've got that network that can do better things in future. And that also links into collaborations overseas with Richard Carvajal, that I said earlier, led the trial on selumetinib, and across in Europe as well. And those collaborations are building. It's really good to see. So my last thoughts are, we do have increasing options available. We need to work out who they're going to benefit, how we can improve their benefits, how we can put them together best to get as much benefit as possible. I really think we need to focus on ensuring equal access across the country. And for this, I think we need evidence and strong policies, really, making sure that we discuss this and work out the best way with the evidence that we have. We need to accelerate the pace of change. And I think that can be, again, building on the successes of having this network of centers to deliver better, bigger trials that can answer important questions. And vitally, we need to translate all the scientific findings that are now, as Sarah was saying earlier, there's a lot of work in uveal melanoma lately, in sort of scientific, and here and elsewhere. And that can form the background to really developing new strategies, new ways of treating this. And I think we need ultimately a step change towards prevention and cure of this cancer, rather than just trying to ameliorate its advances. But it's frustrating where we are, but hopefully we can in future move towards that. So I'm going to end by thanking Ocular, on sort of representing all the patients who are so altruistic with their time in going on trials, and without whom we wouldn't be able to make this. It's that partnership, which is so essential. That's all from me. Thank you.
Thank you, Joe. That was a fantastic summary and presentation. I'm sure there are lots of questions from the floor. There at the back. No, it was you. Yeah.
Sorry, Valerie. What would be the reasons for someone not to be offered MRAs or whatever, just for prevention or whatever, or catching it early? Is it money or?
At the end of, in one session, way it is, yes. So mostly every institution has to decide how, what they think the evidence is for any kind of intervention like that. And the problem has been that there's not that strong evidence to indicate which one over the other. So we know that MRI is more sensitive at picking up lesions than ultrasound, for example. But there are some who would argue that at the screening stage, just to pick up one lesion or so, that an ultrasound is as good. And if you look at the trial done by Tero Kivela and his team, that did show similar sort of pickup rate. They used annual ultrasounds rather than 6 monthly. And although the pickup rate was lower, when they factored in doing it 6 monthly instead, it looked like it would be similar to the MRI. But what we don't have is a head-to-head trial to compare the two. And one of the really important thing about randomization and trials is that can then give you the evidence to go to the institution and say, why aren't you doing this MRI? Why aren't you doing that? And so that we make the best use of resources, because obviously the NHS has to decide on how they use their resources. We are advocates for the patients in front of us when in clinic, but we have to also deal with the whole structure of the NHS, which is trying to think strategically across, if you take money for this, taking money away from there, if you see what I mean. So it's providing that evidence.
I struggle to even get ultrasounds. I had to fight to get ultrasounds because I was told that if it spreads to your liver, you'll know about it because you'll get sick.
So we would argue that isn't right, based on the fact that we know that with imaging tests, we can pick it up before it develops symptoms. And by doing that, we hope that then we have more options available, because if you get symptoms that, once it's spread in the liver, the likelihood of surgery is going to be lower, the likelihood of anything more aggressive is going to be much diminished. So having it at the stage where it's quite early, we've got more things that we can do. Now, to some extent in the past, the argument has been we've got nothing to do. So what's the point of putting you through all of that? And to some extent, it's a chicken and egg situation. If we don't try and pick it up earlier and then try and do have all these options available to try and develop that experience, we won't be able to improve treatment, if you see what I mean. So that argument is still present. I don't agree with it, but I can't hand on heart say that there's anywhere. We've never had a trial that has shown by doing the surveillance that improves survival. It is kind of a stepwise logical idea that if we pick it up earlier, it won't be, won't be symptomatic, etc.
It's you.
It's really exciting to hear about all the trials that come in. I just wondered what exactly is available on the NHS at the minute and what is available UK-wide. We live in North Wales, so.
Now you're going to confuse me with Wales and so on, because I'm not entirely sure the differences in Wales and Scotland. So, sorry, yes, I was going to, and then I got... So the question is really that we've talked a lot about trials and so on, but really, what is available currently within the NHS? And we use the two treatments that we've... So surgery is available in the NHS. There are various theories about when to operate and so on. Our team is quite aggressive and tends to treat immediately if there's a change and any evidence of a metastasis. But that is available throughout the UK, but there will be varying differences in practice. Delcath is being used in Southampton and will be available here as well. Shortly, and that hopefully will go through this process of commissioning by evaluation, which will allow for funding for a certain number of cases with close follow-up. At the moment, we're getting a small number for free to set up, and the plan is that this whole evaluation process will go through. There are other sort of local treatments that, including ablation and sort of chemoembolization and so on, which are available patchily in different parts of the country. Dacarbazine, which is the chemotherapy agent, which is used in skin melanoma, you can use an ocular melanoma on the NHS. And similarly, we've been using ipilimumab at the moment. Hopefully, the nivolumab expanded access program will also allow us to access that in future as well. Now, in terms of Wales and Scotland, I'm not 100% sure. It certainly used to be a problem with ipilimumab, but I think that that's not the case anymore.
I think that might still be the case.
Is it? Okay.
Possibly, yeah. I'm trying to get some information myself. I was deemed high risk after a biopsy last year. I haven't actually developed any other symptoms at all. Sorry to put somebody else who asked the question. We live in North Wales, and my impression seems to be that the sort of pots of money within the NHS that you can use for trials, the pot of money for NHS England, it's a certain amount of however many £100 million, but the pot of money in Wales is zero.
I mean, if you're looking at CDF, that's a sort of English system. Yes, it is. There is a lot of inequity. You're absolutely right with that.
Being able to access some of the treatments you're describing, because I live in Wales.
Yeah.
My concern is that should I develop any sort of symptoms, I would struggle to access the treatments simply because I live in Wales, and that's something I'm just trying to get a bit of information on.
Yeah.
To be honest with you.
Are you having?
Also, just to add on
Yeah.
to what this chap said as well, sort of supplementary question really that you might find a bit more easy to answer. If the biopsy technology for prognosis is so accurate and so detailed, why would you need to wait till symptoms develop before treatment? That would be sort of why I would say about the adjunctive, is it?
I almost forgot there what it was. Adjuvant. No, the problem is always around evidence. So there have been lots of treatments that have worked in certain settings when the cancer is more widespread that don't work in the adjuvant setting. So it really has to show that it works rather than trying for the best, because all of these treatments are toxic as well. And so I think trials are vital in this scenario. But also here, there's also may well be a leap of faith to try treatments that haven't yet been established through big trials in the cases where it's spread at an earlier phase, because we know that the risk is so high. And I think that that's the sort of debate that is very important to think about, because normally if you take breast cancer or something, they'll have a new drug, they'll show it works when the cancer is spread, and then they'll go back and try it just after surgery. But it may be very challenging for us to do that whole process. And if we've shown early evidence that something could work, we can try it when we think the risk is very high, and just have a very close and careful trial. Obviously very close. It's an informed consent issue again, about making sure people are absolutely clear about risks and so on.